All right, I thought I'd just take a little bit of time to answer some questions. I appreciate everybody watching the videos. I'm not much for typing a bunch of stuff, even though I do a lot of voice dictating. And I know there's a bunch of questions that have come up on videos and whatnot previously. So let me go through and just answer some of the questions. And feel free to ask questions, and I'll try to get around maybe once a month or once every other month. Basically kind of answering those via video. First one from Charles, most recent one. Anyone know who this doctor is or how to contact him? So my name's John Kitchens. I'm a retina specialist. I've been doing this for 19 years. I'm based in Lexington, Kentucky. You can find our practice at Retinectomy.com. Basically, I did my medical school at Indiana University, graduated in '99, went on to do my residency at the University of Iowa, which is a fantastic residency program, top 5 residency program, got great training there. Went on to do retina fellowship, a 1-year retina fellowship at the Bascom Palmer Eye Institute in surgical retina back in 2003 to 2004. And then from 2004 to 2005 was at the Bascom Palmer Eye Institute serving as a chief resident. And what a chief resident at Bascom Palmer does is basically they serve as kind of a junior faculty. They do all of the public health trust patient surgeries and care. They administer all the care for the residents. They're chief of the trauma service. They select 2 people from outside of Bascom Palmer, or 2 chief residents every year. And the chief resident track does that accelerated surgical in the first year and then chief residency in the second year. So you get very, very focused surgical training in that situation. And Bascom Palmer, once again, I think 10 or 15 years is the #1 eye institute in the United States by U.S. News and World Report. Fantastic place. Great training, and was there at a great time. So, and I think I was the last person to do a chief residency from outside Bascom Palmer. So that was really great. Love surgery. I see patients in clinic. I travel throughout Eastern Kentucky to see patients and take care of patients. Love surgery. I've been fortunate to collaborate with a few people to develop some surgical techniques early on. I do a lot of work on clinical trials. I've won several surgical video awards. I do a lot of work on 3D surgical video, trying to help push that forward. And we have a fellowship training program that I'm very proud of. And so we train future vitreoretinal surgeons here alongside the University of Kentucky. So if you want to find out more about me, or you want to schedule an appointment, it's retinaky.com, and you can just call the office. So another question was from 7 days ago. Great surgery, doc. Is that an in-grasping forceps? Yes, I mostly use in-grasping forceps, particularly the Alcon number 44 forceps. They're an in-grasping with the shark skin. I really like the shark skin. Didn't love it at first. But certainly do like it. Joseph 10 days ago asked, terrible time dealing with eye floaters. We do a lot of eye floater surgery. That's something that vitreous opacities can be really tough on patients dealing with floaters and whatnot. And we've had a great deal of success. There's 3 things, though, that I think are key to the success. Number 1, in picking the right patient to do surgery on. Number 1 is making sure that those floaters are truly bothersome. They have to bother your driving and your reading. They can't just be a once a week annoyance, or an annoyance when you go to the football game. They have to be something that impairs your life. Number 2, they have to have been there for more than 6 months. In many instances, when you have a vitreous separation that causes most of the symptomatic eye floaters, they will get better with time. And so you want to give them an adequate amount of time to improve. But if they've been there for more than 6 months, they're probably going to stay there and not change much. And then the third thing is, and this is a softer thing, we want to basically have you have cataract surgery already, because removing floaters via vitrectomy will typically cause a cataract. Most cataract surgeons like operating on an eye that hasn't had a vitrectomy yet. And it allows us the ability to get out more of the floaters when we're there, and basically not cause a problem. I should say there's a fourth thing too, is to make sure that you don't have any risk factors for retinal detachment. There are certain things that can increase the risk of retinal detachment, like thinning of the retina inferiorly, prior history of a retinal detachment, retinal tears, and things such as that. Let's see, another question. Do you use triamcinolone in cases? It's a really referring to the patient, to the very tough diabetic patient with mid-peripheral traction. I do on occasion, and I'm going to work on a video that shows how we use triamcinolone in a patient with vitreomacular traction to help identify the vitreous and elevate that hyaloid. I didn't in that case, but in most cases I will. Another question, could you suggest a recording system? Boy, I'll tell you what, we're very fortunate we have the Alcon Ingenuity system. This is a heads-up 3D system. So what you're seeing in our videos is actually what I'm seeing as I do the surgery, and so it creates wonderful surgical videos. There are cheaper alternatives. Digital cameras have really come a long way, and there's some attachments that you can get that you can attach various cameras to record. But it requires some finagling as far as that goes. It really depends on your microscope and what the setup is for that, what kind of digital outputs you have, or what opportunity there is for assistant scopes and whatnot to be put onto the microscope. But the one I can highly recommend is the Alcon Ingenuity system, and this can be fitted to almost every microscope and allow you to have heads-up 3D surgery. And those systems, since they've been out for a while, I think you can probably find used ones hopefully for around $50,000. Seems pricey, but for the kind of visualization that you get, the documentation, absolutely great. So typical operating time for a buccal vitrectomy in our situation is usually about an hour. And I do like to put my patients who are having a buccal vitrectomy under general anesthesia with a laryngeal mask airway. I just feel like if I was getting a buccal on my eye and I was going to have a surgery where I had to lay there for about an hour, I would want to be asleep. And so unless the patient has any contraindications, we do typically like to put you to sleep for anything that's going to be more than, say, a half an hour surgery time. In your hands, how much time does it take to remove heavy oil through a 25 gauge trocar? We don't use heavy oil in the States. We use just basically silicone oil. I typically like a 1000 Cinesoak silicone oil. It comes out pretty nicely. I can usually get it out through a 25 gauge trocar with the VFC system utilizing the Alcon Constellation machine in about 3 to 5 minutes. If it's 5000, it's going to take about double that amount of time. Heavy oil is something that we see used internationally more often. It has a greater density and it's a lot tougher to remove. Another question, do you routinely cut the PC in pseudophakic eyes while removing symptomatic vitreous or silicone oil? So basically, yes, if the patient does have a posterior capsule intact, I'll typically open it. And then as far as non-emulsified large silicone oil bubbles in the AC, I'll usually utilize a paracentesis, and I'll typically try to go in my cutter actually and take that silicone oil. If it's a large bubble of silicone oil, I'll actually go in with the VFC 25 gauge, engage the oil bubble, try to engage the oil bubble right away by tilting the eye so the oil comes up to you as it's going to float to the top. And then that way you don't basically collapse your anterior chamber. Let's see, as a retina fellow in West Virginia, underserved is something that gets me out of bed every morning. That's wonderful. Absolutely. James Dossett. Yeah, I'll tell you, we've got the best patients, are our patients in Eastern Kentucky. They are absolutely the nicest, sweetest, most genuine people in the world, and it's a joy to take care of them. Let's see. So great video. Can you talk about talk about the reasons of your patient's retinal detachment? Do they have any other eye conditions? And some of the discussion about patient's condition after surgery. So yeah, in this case, I think the healing up did just fine. What I'll usually tell patients before they have a retinal detachment repair is that depending on the technique, we have anywhere from an 80 to a 95% chance of a single operation surgical success. In general, in my experience, patients that have a primary vitrectomy in my hands have a closer to 80% success rate. That means no further retinal detachments, and one surgery takes care of reattaching the retina permanently. That goes up if there's a buccal involved, usually to 85 to 90%, and if it's a buccal vitrectomy, usually 90 to 95% success rate. Having that buccal on the eye really helps give additional support around the peripheral vitreous. I'll tell them a recovery time is typically going to take about 3 weeks before they'll get a significant amount of vision back. If they have a macula off detachment, we can't promise that their vision's going to come back 100% to what it was before the retinal detachment. There's always some damage that's there, but it's always surprising how well patients can do and how well they can do fairly late after surgery. We see patients that can recover 2 or 3 more lines of vision 6 to 12 months after they've had their retinal detachment repair done. And that there will be a refractive shift in most instances with a scleral buckle. And we'll usually use just antibiotic ointment twice a day for a week. We do not need any steroids in these patients. We haven't needed any atropination for these patients, and we don't use any narcotic pain medicines. Even for buccal vitrectomies, we find that it's manageable with just oral Tylenol, ibuprofen if there's no other risk for bleeding and whatnot. When I use cryo, often postoperative inflammatory reactions in the anterior segment. I'll tell you, it's not uncommon, especially if you use a lot of cryo, to get anterior segment inflammation. Maybe consider at the end of your case a subtenon's Kenalog injection. Once again, any advice I give during this, take it for what it is. It's not giving out medical advice for any specific conditions. Great video. Could you identify a causative break, or is it just thought the laser where it was dry? In some instances, when we don't find a break, and I believe in this situation I could not find a break, we will just go ahead and laser once we've got the retina flat, and either in this case leave PFO in the eye for a week or two, or go ahead and put a gas bubble in. In those instances, I'll usually laser everywhere that the retina was detached, all the way out to where the vitreous base is inserting, and then a little bit anterior to that. Sir, did you use SF6, C3F8, or just air? Actually use SF6 for most of my cases. I can't remember what I did from that standpoint. Let's see. Let's see. Let's see, there's a question from AJ Rose, 79 years old, don't use this drug, 20% of people who dropped out. There was a lot of dropout as far as that goes. I tell you, and I should do a whole separate video about GA treatments, geographic atrophy treatments. It's such a hard thing. Geographic atrophy causes significant vision loss for patients. There's no doubt about it. And the medicines that we have now, although they are a breakthrough because they're finally something that can actually slow GA down, well, I'm telling you, it's such a squeeze for the small amount of juice that you get. It's a 20% reduction in progression of geographic atrophy. Very rare inflammatory events, so I'm not worried as much about the inflammatory events now as what I was when they initially occurred in July of last year. But gosh, it just does not improve vision, and we're so used to improving vision. So it's hard to know what the right answer is for GA therapies. I struggle with it myself. I'm finding that patients who've lost vision in one eye from GA and have foveal threatening GA are probably the best candidates for treatment. But I just wish it was a lot better. And I think better things are coming. But for now, the 2 drugs that we have, Izervay and Syfovre, are at least an advancement on nothing. And I think as a patient, you just have to understand it's not going to make your vision better. It's quite a commitment to come in every month or every other month to get the injections. Injections aren't without risk, but the risks are low, and it's going to slow it down by 20%. Let's see. Do you no removal of the anterior flap? In that situation, I did not remove the anterior flap on a retinectomy. Actually, if I can do a retinectomy and get the anterior flap to lay flat on the buccal, and it's been lasered previously, or I can get it flat and laser confluently and get a good oil fill, I find that it doesn't redetach and doesn't cause anterior loop traction. But in those instances where it is starting to foreshorten when I go in to do the retinectomy, then certainly I will. Let's see, Bruce Willis. I've gotten that before, actually. It's so funny. So the 6 reports of retinal vasculitis from Syfovre. Yeah, that was an issue. The risk looks like it's about 1 in 10,000 patients. And to my knowledge, from what I've heard from the company, as recently as about a month ago, there's been no cases that have occurred beyond the first injection. So if you've gotten 1 injection, there's some thought that, subsequent injections are much less likely to cause a risk. Let's see. A lot of stuff, yeah. And the cost of the GA therapies. I will certainly admit they're expensive for what you get out of them. And, they've basically, the European Union has come out and has decided not to approve these without further data. So, they're certainly, really looking into the cost and effectiveness of this. They're a little more cost conscious in Europe. What's the posterior viewing system that you use? I use a Biome with the disposable Biome lenses. I like disposable lenses because I really do value high quality surgical video. Let's see. Yes, and then the other thing is the retinal transplant videos. I've shown some retinal transplant videos, and unfortunately, it looks really good anatomically after they're done. And I had a couple of patients that swear that they can see better. I've done microperimetry on those patients, and I just don't see the retinal tissue functioning. I still will do it in rare occasions. I wish we had some evidence that retina reconnected, but for now, I guess it's sort of my third line therapy for patients, and I wish we had more data surrounding the fact that whether or not it actually worked. But some patients claim that they certainly see better after having a retinal transplant for a large full thickness recurrent macular hole. And yet in those patients, I can't see any microperimetry benefits. Microperimetry, by the way, is like a small way of testing a very focal visual field where you can actually see the area of retina that you're testing and test a response to see if a patient can see. That being said, and when you look at the OCTs afterwards, it sure looks like it's normal, healthy retina. And I've had one patient who's developed macular edema in that retina after a retinal transplant, which is just crazy to think about. So anyway, I wanted to keep this relatively short. I appreciate everybody who's watching the videos and just wanted to answer a few questions I've gotten over the last year. Feel free to keep watching. I'm going to post more surgical videos, maybe do more stuff like this as far as that goes. Certainly if new things come out. I'm going to several conferences. Maybe I'll highlight some of those conferences and talk about some of the meetings we go to and some of the things that just makes being a retina specialist so great. It's a really great field. Anyway, thank you for watching and keep tuning in. Thanks.